I'm happy on behalf of RISE to welcome you to our webinar today. We're so thrilled to have Drs. Reid and Andrew Pinto with us to provide an overview of population health management, similar to what they provided for those who were able to join the two-day OHT forum that took place recently last month. I'm going to start us off just with a couple of overview slides, and then I'll pass it over to them for the majority of the time, and I'll come back to moderate the chat and wrap us up at the end. So just to set everybody up here, we're really interested in population health management as OHTs because the whole vision of the OHT model is about a shift from reactively providing care to people who walk through the doors of our health system, that's generally the way we all have been operating, to more of a proactive management of a whole population, including health promotion, prevention, treatment, and care. So it is a complete shift in how we think about and design and deliver care. And that's why it's so critical that we lay the foundation together so that we're all on the same page and understand what this means and can talk about the implications for our local OHTs. I have to provide you with a few acknowledgements and caveats here. So RISE provides evidence-based support to OHTs using a rapid learning and improvement lens. We're part of the ministry's central program of supports for OHTs. We're one of many supports that they've put into place, but just to remind you who we are and what we do, we prepare our own resources like RISE briefs and host this webinar to support rapid learning and improvement and allow teams with a structured way into resources prepared by other partners and by the ministry. So we're supported by a grant from the Ontario Ministry of Health. The opinions, results, and conclusions, both conveyed in our resources and events like this, are those of RISE and independent of the ministry, and no endorsement by the ministry is intended or should be inferred. I just briefly, before I turn it over to Andrew to do a land acknowledgement, wanted to mention that we have been really focused on ensuring teams understand the building blocks that the ministry has identified that they need to put into place in order to achieve the goals, the quadruple aim goals of OHTs. And in particular, population health management and population health management for year one priority populations fits really nicely in patient care and experience, which is building block 4. So just to connect in back to those building blocks, this webinar is really focusing on building block 4, but as I mentioned, it's actually quite foundational to the whole thinking and all of the activity related to each of the building blocks. So it's a really critical component. So with that, I'll pass it over to Andrew and Rob.
So thanks so much, and it's a real honor to be presenting to you today about population health management. And as we get started, particularly on this topic, we just want to begin by acknowledging the land on which we're meeting. So Rob and I are in Toronto, and this is the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit River. And it continues to be home to Indigenous individuals from across Turtle Island, and we really respect that and appreciate the opportunity to meet and to learn together on this land. And so with that, population health management, this is a topic that we talked a bit about at the February 20th RISE event that many of you may have joined. So we want to just go over some of the principles but have a bit more of a conversation with you all about the things that have come up for you. So we're going to cover some of the topics and kind of key lessons from the February 20th date, but also recap some of the things we heard, and then open it really for discussion.
Yeah, I think so. And so, Andrew, maybe we didn't get a lot of time to discuss at the forum, and maybe we could just talk a little bit about ourselves.
Yeah.
And maybe you could just kind of introduce yourself a bit and what your background is and what you bring to this this topic, and then I'll just drive you the same. Okay.
Sure. So I'm a family physician, and so I work in the front line here at St. Mike's Family Health Team. So I have that perspective, but I also am a public health and preventive medicine specialist. So the training that is the route that people go into to become medical officers of health, who are very much in the media these days as they do a wonderful job with tackling COVID. And I then kind of took a route to engage in research. So I'm a clinician scientist, and I run a research team called the Upstream Lab, which is focused on tackling social determinants, integrating health and social care, and really taking a population approach to our health system.
Yeah, and Andrew, you and I have actually similar backgrounds because it's Rob Reid here. I'm a primary care physician by background and also a public health doctor. So that's the similarities that we have. And yeah, I probably bring my expertise to this is spending probably more than a decade at a large integrated health system in the United States as one of the medical directors of what we would now term population health management. That term it was term something else, but it really is driving around improving health for an entire population served by a system. So it's I bring that to bear on this topic. So why don't we start off with slide 5? And I think the central challenge, I think Andrew's quite right. We're just going to have a little bit more in-depth conversation on these slides because what we've heard from people in the interim since the OHT forum is that these are challenging concepts, and we wanted to again anchor people in the core things and bring a little bit more meat to the discussion. Okay, so a central challenge for Ontario health teams is actually really around integrating and managing the continuum of health services. So putting all the pieces together for actually a defined population of patients. And that's the kicker to some degree, is we actually now are thinking around defined populations that our OHTs at the maturity will be accountable for. And they'll be accountable for really trying to kind of improve the health of the entire population. Andrew, could you help us a little bit with that concept of, because it's a slippery one. What is this whole population health thing? Because people, we hear different themes in that notion.
So it's really, this is a lot about shifting us to think about our entire group of people that we're serving. And maybe I'll just go to the next slide to kind of put this graphically. We, of course, are very good at kind of focusing on the individual in front of us, but this is our challenge with population health, really thinking about the health outcomes of the entire group and how that is distributed. So where are people on the spectrum of unhealthy to healthy? And a really neat thing is that we should be proud of Canada's role in developing population health as a concept. Many of the leaders of population health thinking are Canadian, and this is a wonderful kind of journey that we're on, moving into the space with integrated care models. And as you can see, it's not only about improving the population health, kind of the middle of this or the mean, it's also about this idea of equity. So that's inherent. How do we make sure that the people who are at the lower end of this distribution are coming up and ideally even improving faster than others? So
Andrew, it's really around moving the whole population and paying attention to everybody, right? And it's actually making sure that we're not leaving groups behind, which unfortunately in Canada we have proof of that there are many populations left behind that you study actually. Right?
Yeah, exactly. And in fact, for everybody joining us, a question to ask is how you are identifying those inequities. How are you thinking about them, and being able to track whether your efforts within in creating an OHT are contributing to this problem or being part of the solution. And we see this as blending both the idea of not leaving no one behind, so really being able to think about our whole population, but also tackling this inverse care law, the law that has been identified through many health systems, that those who are most educated, the most well off, and often the healthiest actually are the ones who are able to access services more than others. So thinking about this concept of equity, it also confronts us with this point that actually what determines a lot of our health is outside of the health system, are these social circumstances and behaviors that determine health. And we have an opportunity with Ontario Health Teams to take a step towards combining interventions on both the biologic and through our traditional healthcare services and through social interventions as well.
So it's kind of merging, right, Andrew? It's kind of merging healthcare and public health thinking.
Yeah.
So that we actually are addressing a whole population at a population level, as well as serving those populations at an individual.
Yeah. And to make this a little bit more concrete around what does this look like, here's 4 different pieces of a population health approach. And these are all things you could take away and say, are we doing these? Are you identifying systemic variations and patterns in how people are using the system? Differences based on people's age, sex, their gender identity, their income, their postal code, their disability status. So thinking about, can you identify those? And with the data you have, and what data do you need to go further? A population health approach also focuses on these conditions and factors that are underpinning that distribution. So bringing together the health and social care that people need. It's about developing new services and policies. So it may be about changing how your organization does business. We're seeing right now, in response to COVID, we're making rapid changes to how we're delivering services. And there's lessons we can learn for changing our business in response to more non-communicable disease and to other things that we need to consider to improve health and well-being. And finally, this point, which we'll go through some examples of, this can happen at the individual level, but it can also happen for your whole population as well.
So what do you mean by that? So let's just anchor what we're meaning by services at an individual level and a population.
Yeah. So let's go through kind of these 3 examples. So if we think about, for many Ontario Health Teams, they have an interest in improving care for people who are near the end of life. So at the individual level, this could be improving access to palliative care programs. But at a population level, it could be about broader education of your whole population about things like advanced care planning, getting powers of attorney in place. And this actually could lead you to develop new relationships with the people who help patients with these things. It makes me think a bit about things like medical legal partnerships or other partnerships with social agencies that could help spread the word about this. And similarly, we could think about this for frail older adults or people with diabetes. Diabetes is a really key priority population for many OHTs. And if you think about it, often we're focused on improvement at the individual level, but what else could be done at a broader population level that even gets into more long-range thinking about things like our environment that we're in and the people around the table in our municipalities who we could partner with to advance things.
So yeah, those are, I think, Andrew, you've done a nice job of, these are priority populations for many of the OHTs to begin with, and kind of really, putting us into this new world of how do we merge both care for people and public health thinking.
Yeah.
So that's terrific.
So how about, Rob, you take us through how we can link this population health thinking with healthcare?
So I wanted to spend a little time with you, and I know some of you have heard me speak about this before, but it's, we often don't think about how healthcare, serving people at an individual level, can actually improve health at a population level. And that's actually one of the key components of Ontario Health Teams that we're just talking about, is applying health services in a way that maximizes benefit to the whole population that you're serving. And so I'm going to dig into these concepts just for a minute or two, because these are tangled, slippery concepts, Andrew. So, and we're getting lots of questions about them. So This slide really tries to take that slide that Andrew showed you a few minutes ago about the distribution of health in a population and break it down into several segments about where health care actually fits into the services. So we've got three different curves here. Let me just talk first about the black curve, which is the bottom curve, and this is the one that people in hospitals and primary care teams and all over the place actually know really well. And this is about actually delivering consistent, great acute care consistently one by one. So it is really focused on individual care and serving those acute care needs. So for instance, a rapid stroke assessment center, or we know that rapid assessment for stroke, people that have stroke, and early treatment with intravenous thrombolysis and endovascular therapy can substantially reduce post-stroke mortality and disability for individuals. And if you apply that consistently at a population level, you will achieve population health impact. So the application is at the individual level, and it's just applying these services in a very accessible, quality way, one by one. So I wanted to make sure that we don't forget this, because this is a core competency of Ontario health teams as they go forward to continue to deliver accessible, high-quality acute care consistently to the populations that they serve. Okay, let's not talk. We won't go over that one anymore because I think everybody knows that curve really well. The second curve is actually where much of the action currently is in Ontario health teams, and this is the yellow curve. We're going to call this the clinical population health management curve. And the care here is not focused on acute problems, the one I just talked about, but the focus here is on chronic, ongoing conditions, medical and psychological conditions, and about changing risky health behaviors like tobacco and substance abuse. The philosophy of this second curve is, rather than having a reactive approach to care, like you would do in an acute care setting with acute problems, the care is actually now moving to be much more proactive and planful. And the attention focuses not only the users, but now also the non-users, the low users, the entire population with these conditions. And some of those go unnoticed and unrecognized, and they fall off the map, those people. And so this, Andrew, is where I think the equity lens now really comes in and is critical, and is bringing people back in and addressing those barriers to care that you so well talked about because of the social determinants of health. And so at the heart of this second curve is really about making sure that people with similar needs are identified. So patients that are frail, one example. Patients with particular mental health issues is another example. People with particular chronic illnesses or burdens of morbidity might be another example. And that we consistently apply care across the populations, longitudinally across the care partners, okay, in any OHT. And this one is the main work for OHTs, okay?
And I think, like, if people take one piece away, it's this word proactive.
Right.
So that, to me, is really the heart of this. And as you said, the new focus, or even the main work for OHTs, is proactive thinking.
Yeah, exactly. And because we know that some of the people that are ending up in our emergency departments, I work at a hospital, if we had addressed their care proactively earlier on, we may not have gotten that to that stage. Better for them, better for us, better for everybody. Okay. And then the third curve is a next curve, and this is also a really new one for Ontario health teams. We're not the focus. It's not going to be the focus of this presentation per se, but this is not actually about healthcare. This is squarely on the upstream determinants of health. And we are applying population-based interventions and policy like healthy transportation policy or built environment policy the healthcare community is vital here, and they can provide services, they can facilitate, and most importantly, they're important for advocating for healthy public policy at a community level. We're going to come back to this in future webinars and really talk about this curve.
Yeah,
okay?
I think as we see OHTs advance and get into the second curve work, I think you could envision Rob and I coming back in the future, maybe next year, to really advance this third curve and share some ideas.
Yeah. So, and I know some of the OHTs are already on this journey, and some are really focusing on making sure that they're delivering really good chronic illness and chronic condition care to a population, which is the focus of this year's much of this year's work. Okay. So let's now. I want to spend a little time now just talking about. Okay, we've talked about the philosophy of producing health and populations, the second curve here. How do we actually do this? And how do you manage a whole population, and particularly in this second curve? This schematic really talks about the 4 steps. And in the OHT forum that we had a couple of weeks ago, we had stations for every one of these steps, and each of the groups was learning about how they might apply this philosophy in terms of producing care. Many of our teams are very far along on this, and then some of them it's very new thinking, and we're all on this journey together. So the first step in this whole notion is really understanding who the population is, right? It's actually identifying those priority populations. And to do that, we actually have to segment the full population so that we actually find the priority populations that we can be the focus on. We don't want to leave people behind. So it's not just focusing on the users, it's actually understanding everybody in those priority populations. And that's the first part, is about segmenting the population and finding them. And then, as Andrew said, you're right, it's actually characterizing what their needs are, and it's broader than just their medical needs. It's also about the socioeconomic determinants and barriers to care that we actually have to address, or else we won't address the full population. Okay, so that's the first step. The second step is, now we know who the population is. It's actually about designing the care pathways. I mean, how do we design the proactive care that we were just talking about, Andrew, so that with patients and families and caregivers, so it's sensitive to the needs that we talked about, and making sure that it's now proactively applied. We talked a lot about virtual technology, and it's particularly apt for proactive management, to be able to reach out to people using virtual care. And then mechanisms for both in reach, making sure that when we see people at our emergency departments or in our clinics, that we're addressing their needs, as well as outreach to them when we don't see them and they get lost. Okay, so that's the second one. And the third step on this whole thing is all about implementation, and it's making sure that whatever we're doing actually has reach and reaches across the population. I'm not going to talk anymore about implementation. And then the fourth step is really around measurement, monitoring, evaluation, and making the adjustments so we refine this approach over time. And I know Walter Watches did a webinar, a recent webinar on using logic models around actually a tool that we use, or driver diagrams, to really understand that measurement framework around moving forward for us. Okay, so those are the 4 steps, and we had parts to each of them. Okay, now I want to step back a little bit and just again anchor in the population, because that's what we're going to start with. Step 1 and 2 a little bit more in depth here. The first step is really around understanding and who these people are, right? And we have to realize in this diagram, the population for an OHT is everybody in that, if we can think about it, in that blue triangle. Okay? that's the entire attributed population that we're beginning to understand and we are responsible for as OHT partners. But we realize that that population is not static. It changes. We have people coming in, they're born, unfortunately some die. They immigrate, they emigrate, there's mobility and choice, and they move across. And we have to account for that dynamic population over time. And so that is one of the tricks in population health management, is understanding how the population is changing in terms of the inflow and outflow of people, okay? That's a core competency, is being able to understand those transitions. Let's move to the next slide. Okay, so then we have the whole population. Then we actually have to now segment the population. And this is another core slide here. This is the Kaiser Permanente risk pyramid, and just a conceptualization of how population segmentation occurs. Everybody in the population has planned care needs, whether they be chronic illness care needs, very intense needs, or simple prevention needs, tobacco cessation, screening, those types of things. And what we do with population segmentation is actually segment the population into different populations with different needs. And I know all the OHTs here have started to do this by picking priority populations. And their priority populations generally fit into one of those slices, but some of the priority populations fit into all of the slices, right? From the very healthy to the very sick, okay? A principle in population health management is identifying and segmenting your entire population from the most healthy to the most medically complex, where I've called super users here, okay? And the reason we do have to do that is because each of these segments has different needs that we actually have to design strategies for that are different, okay?
Maybe that's a nice kind of segue is to think about, once you've done this, kind of what's the next step to how you do things differently for each segment.
Right. And the the core on this is actually really now thinking about the programmatic approach that we would apply to these different segments as they're coming in and going out. So if we look at the real healthy patients, it's really around engagement, around screening and counseling, and around providing navigation services. Many of them have acute care needs only, but many of them actually have chronic care needs. As we move up that pyramid, we move into the people with the emerging risk categories, the people with chronic illness, some of them with multiple chronic illnesses, depression, diabetes, and so forth. And this one is actually developing consistent chronic illness care approaches, collaborative care programs, coordination programs. They have more needs, more complexity here, and their care stretches across many of the OHT partners. As we move higher in this pyramid, we get to the medically complex, or the high risk group. And then this really, is a high using segment. They often have multiple chronic illnesses all occurring at the same time. And an example for a management strategy is a high risk care management program that this segment is actually used. And then finally, it's often the very high users that really do need high risk care management. Often they're towards the end of life, and palliative care programs are really essential in this part. So if we can start applying this pyramid to the OHTs, I think it's really useful. At maturity, OHTs will have to have programs across the pyramid, right? But right now we're just focusing on one or two priority populations in this pyramid. So this is just my way of also showing that this pyramid is dynamic as well. So people will move up and down this pyramid. Unfortunately, many of them move up from emerging risk into high risk, and the hope is that we can keep them from moving up. We can keep them at the emerging risk category, and sometimes they actually move down. But what's really critical in this area is that we're not over-servicing people. because one of the aims of in this whole initiative is to make sure that we're judicious in the amount of services provided, so that we're cost sensitive. So we don't want everybody served with high risk care management that actually really doesn't need it, right?
And this is something that that you and I have talked about, which is the need also for OHTs to be flexible and to adapt the services to where people are at based on this hierarchy, and including, once people are more stable, actually to move them to a lower level. Sometimes in our system, people get identified as a higher need or higher risk individual, and they are stuck then in that category. People can move down, and we know that, and that allows resources to be freed up as well.
One other comment that we got across before is, so where does primary care fit in this, right? And where does the hospital care fit in this, and so forth? And it fits in the different places. One of the clear knowledge from the world is that primary care is essential, but it's essential in all of the pyramid, okay? So you actually have to have primary care linked at the prevention level, at the emerging risk level, at the complex care management level, and actually at the very high end level. Primary care is an essential component of it. The other essential component that crosses the spectrum here is self-management support. So providing patients with support around and caregivers with support around managing their own health trajectory across those levels. And then finally, the integration of mental and physical health is also core. So one of the learnings across the world is that we really ought not to be dividing physical health from mental health delivery. There's been a lot of places in the world that have tried that, and the problem with that is that many people have both those conditions, and it has to be managed conjointly. Okay.
So I'm going to just talk now a little bit about how.
So like, okay, Andrew, we've kind of gone through that. We have to segment the population, and we have to understand their needs, but you kind of only do that with data.
Yeah.
Like, how do you do this?
Yeah.
Okay.
And we know that OHTs are at the very early stage of starting to delve into this.
Yeah.
And so one point is that the data can come from multiple different sources. And this just shows that there can be the patient-generated data that comes about from the work that we do with individuals. There can be rich administrative data that supplements that. All of the Ontario health teams have received packages of data from ICS and from others and from the ministry around who their population is. There's developing registries and being able to say, this is our list of patients with diabetes, with COPD, with CHF, and using that.
All our patients.
And
Yeah.
all of our patients,
Right.
exactly.
Yeah.
Having that denominator available. There's also new areas like community and contextual data. So what do we know about the context which patients are living in? And you could go even further to say, what's people's proximity to community assets and other social services that are going to assist with this as well.
So Andrew, where do we get data? Like in healthcare, we only have data generally about health services. Where do we get data about those contextual factors and what our communities look like?
So we're in the really early stages of this. We our lab is doing work around using things like information that's collected from individuals to help build that picture. Just going onto this, we're what we call robust sociodemographic and social need data. And we also could use things like people's postal codes to say what is available locally to you and how does this relate to your health. And this is just giving you some sense of how information from electronic medical records is being used and has been used by many of you for things like quality improvement efforts and sometimes where you've participated in research. But what we're starting to develop, I think, in Ontario is lessons learned around using data that's pooled from different sources to really create both a way to identify where the gaps are, but also measure our progress.
Yeah, and we won't talk anymore about data on this webinar because we'll have more webinars about data and how to and analytic techniques. One thing I wanted to put a plug in here was our public health colleagues. Is that the public health units across our system have rich data about our communities, and we're finding that right now clearly with we're seeing this with COVID. Is that the public health partners are key in the data exploration of our communities as well.
And we know that we have a ways to go to develop in every OHT capacity around working with large amounts of data, but I think that's beginning, and again, RISE and these webinars will be a place to share that.
Okay, so let's now move from the segmentation and the characterization of the population to now a little bit on this step 2 of the population health journey and population health management journey, and this is really around, okay, so what do we do with this population to make things more coherent and smooth that reaches the full population? I wanted to introduce this diagram to you. If you haven't seen this diagram, it's something that it's an important contributor in the world over the last 2 decades. It's a chronic care model that was developed by Ed Wagner and colleagues. This diagram is actually an expansion of the chronic care model that takes in more of the population health aspects of it. It's really showing what are the core components that are needed to make for a proactive system that serves a population to deliver care consistently all the time so that we actually have informed, activated patients, and we have prepared proactive care teams to apply care, okay? And so this is a very, very helpful model in terms of thinking through your population health management approaches, and I would encourage you to use it. And we can certainly give you more information on this model as well. I wanted to focus really on the 4 circles that are in the health system component of the model. What can the health system do to actually deliver proactive care more consistently to patients, be they elderly patients or chronic illness patients or patients with chronic behavioral health needs such as tobacco cessation or substance abuse. Those 4 components are really about designing this delivery system in a different way. And this is about new roles and new tools that cross the OHT, that do not center in just one partner, but they're across partners. It's around developing in-reach and outreach functionalities, and as I mentioned before, it's around virtual care often. It's around actually developing care coordination functions and the judicious use of care management. And then again, it's around mechanisms to identify and address barriers to care. So in that component, it's really around the delivery system design. Okay? The second is really now making everything really proactive, okay? It's about those clinical decision supports that really are articulating how patients move through their care, okay, over time. And it's about using clinical guidelines and practice guidelines, clinical pathways. And it's about those prompts and reminders for patients and providers to make sure when they fall out of care, we're reminded back to get back in, okay? And then it's about having clinical information systems to support that. That includes population registries, trackers, and then finally, and I don't want to underestimate this and undersell it, it's actually about building patient self-management. At the end of the day, this is about often behavior change around chronic illness or around prevention, and it's around helping patients in terms of building their motivation, skills, capabilities for that change. So self-management support is key. Okay. So this is the last two steps, and we're gonna end this fairly soon after an example. These are the last two steps of the population health management thing, or approach. We're actually not going to focus on this because Walter did a seminar on logic models, and we'll talk more at different times about implementation. But we have this slide in here just for your reflection. Okay, now Andrew and I talked for a bit about what all these things are, and we've given a lot of words, and and maybe it's not that clear, and so maybe an example with them. Okay, so I want to anchor in an example. Now it's just one example. There's many different examples across the world, and this one I picked from Boston, but we could have picked one from lots of different places. And this one is about a segment of the population that is a common one that the OHTs have selected. Okay, and this is around patients that are medically complex, that often have multiple medical conditions and actually have substantial amounts of care coordination and care management needs. Okay. So this example is of a high-risk care management program that has been developed at Partners Healthcare, which is not unlike an OHT. It's about the size of many of our OHTs. Got many different partners, primary care partners, hospitals within this partners framework that have agreed on how they manage this population of complex patients. So it's actually not that dissimilar to what we're trying to do here, even though that it's in Boston. And so this population really, this intervention really defines very clearly who those medically complex patients are. They define them as having chronic illness and complexity in the following ways. They have to have multiple chronic illnesses, some of which have to be severe and persistent. They also say that in this population, we're only selecting those, or we select those that have mental health or substance abuse that complicate the management of those medical conditions. And they often have socioeconomic factors, poverty, unemployment, social isolation, that complicate the medical management. Okay, and they're very clear on what bucket of patients that they're managing, and in general, it's about 8% of their entire, we would call it their attributed population here, falls within this bucket. Okay, and so how do they find them, and how do they determine them? They actually use a tool, a segmentation tool, a predictive risk score that they use to segment and identify that population using prior diagnosis data, not unlike what we would do here. We could apply this type of technology here. And they also supplemented by clinical risks that are collected in the EMR. Okay, so absolutely similar to what Andrew just talked about, and I know that we often collect social risks within our EMRs. And then they want to make sure that these are the right people. So they confirm the enrollment that this is a medically complex patients with their primary care clinician. So that's how they segment and how they identify those populations. Okay. So what do? So this is the care design component of what happens at Partners Healthcare. They actually, in terms of their delivery design, they actually use a care management model, and they have a care manager that actually has a rostered group of people that is actually embedded in primary care, because remember I said that primary care was critical. And they apply a whole variety of outreach and in-reach technologies to make sure that they're managing those patients proactively. The use of home visits, telemonitoring, virtual care, post-acute integration. Okay? They have a variety of self-management supports that are used by the care manager generally, but also by the primary care team. Like said, within very defined structured care plans. They have goals of care conversations so that they make sure that they're aligning with what patients want, not just what we think they wanted. And they actually have systematic case reviews with physicians and medical experts around those applications. And they have training programs that they support the training for particularly these care managers around how to manage these complex patients. So in some respects, it's like the bundle, or not the bundle care program that we had before, Health Links, but a more systematic approach than many of the Health Links had. They have registries, care coordination tools, real-time notifications, so that they prompt care when it's needed if a patient ends up in a hospital and so forth. And then they actually have a fairly well-developed patient self-management support platform, because they actually also understand that that's key in terms of health coaching, shared decision-making tools, and the like. Okay, so this is what the program looks like. People are asking me and ask us about, like, okay, tell us more a little bit about this care manager and what they do. And this is just an example of what's done at Health Partners, is they really realize that this is a precious resource. And so they really make sure that they have the right type of care manager serving the right type of patient. So for patients that have medical complexity, they actually use registered nurses. For patients that have mostly psychosocial complexity, they use social workers. And then those that are actually mainly social complexity, they actually don't use healthcare workers. They use community health service work. They use people in the community to do that. And they have dedicated panels for that. So, you know, an RN might have 130 people on their panel of complex patients that they would have to manage. And, you know, a social worker might have 60, okay, that they actually have to proactive management. But they're all generally responsible for the same types of things. They actually have to do the patient assessments and systematically, risks and gaps, develop care plans, conduct the systematic case reviews, provide care coordination, communication and transition plannings, and actually really engage patients about providing self-management supports and care coordination services. So that's their role. And then they have a supports built in with the team. Okay? So that's, and you can imagine that that's an expensive resource. So what Partners is very clear on is making sure that they're targeting those patients where they really need those services. And if they no longer need those services, that care manager will come out of the mix, and they'll move down into their other care programs that are not at this slice of the population health management. Okay, so that's, I think, it. And people are asking, so what's the proof points on this? And if we look at the quadruple aim, this and they publish this now, is that not surprisingly, patients like this better. Okay, so for that population, they feel that their care is more coordinated. They feel that they're getting what they need more, and they feel, and the families feel that the patient report. The quality is actually better in terms of the delivery. You know, patients that they're actually getting more advanced care planning and so that type of thing in those programs. But what is also important is that their cost trajectory has actually gone down. That this resource that they're putting in pays for itself because it's avoiding high cost hospitalization. So that you know, they're a business, and they've been able to show that there's a return on investment based on this type of program. Okay.
It's a great example that goes right from how they segmented their population. So step one, developed a new program. Step two, and then monitored it and evaluated it. Step 3 and 4, and evolved the program.
Right.
And it's actually something that's informing some of the models and interventions that we're developing now. One kind of similar program found that for every $1 invested, it saved $2, right, and the rest of the system.
But it's core that we make sure we get the right people into the right intervention.
Yeah.
Right? Especially with these very intensive service models. Okay.
So we just wanted to end on some of the points we heard from many of you and others who attended the February 20th event. So just some points on the first part of segmentation. We know that there's different experience and different levels of expertise at working at this population level, but some common challenges were where should we start with, say, a population like palliative care? Where do we begin with that? Do we start as people are at risk of needing palliative care in the next year, or do we go to people who are already engaged in palliative care and make sure their care experience is better? Do we focus on a single condition like diabetes, or do we think about people with multimorbidity or many chronic conditions? And also related, how do we integrate these different pieces, the physical, the mental, and social issues? Often there's a need around access to data, and a point was raised that it's about both the quantitative but also the qualitative. We need to be capturing that as well.
And those are all actually really valid, common challenges that everybody is facing. And we will, as part of the RISE community, will be helping OHTs to deliver that. Okay.
So on step 2, there was a lot of, again, different experience around developing and working with patient partners around co-designing interventions. There's a need to say we don't need to recreate a pathway in every single OHT, so we need to bring together teams to share lessons across OHTs when they are working with the same population, and a strong focus on making sure patients are involved in that.
Andrew, why don't we stop now? And
Yeah.
we have a few minutes left. And why don't we just open it up to a few questions?
Yeah.
If anybody has a question, I'm not quite sure how
Yeah.
to.
I think, we'll end there. And there's, all of this information is available for people to reflect on afterwards. But why don't we just open it to people's questions that they may have? And please, as Heather said, kind of if you can type your questions into the chat box, that would be great.
So thank you, Rob and Andrew. I have one question that came into the chat a little earlier, and it's it's commenting on the size of the curves in that those few slides that you had with the curves. So Marjorie was saying the sizes of the 3 curves don't seem proportional to the number of individuals, in brackets, proportion of the full population we would be focusing on with each approach. Can you comment? And then she elaborated, the dark curve seems too large, at odds with what we know about the very small portion of time that patients actually spend with healthcare providers, even when they have serious medical conditions.
Yeah, that's a really good question. The curves are not reflective of the size, so they're really for demonstration purposes only. So we could talk about the 3 layers of curves. So I wouldn't draw anything about the size of the curves at all.
Mm-hmm.
Okay,
it's a good point to the point that was made in this question about that the amount of time people spend with healthcare providers, even those with complex health and social issues, is small, which is kind of a key point in population health. It's a lot about what's happening with people when they're outside of our institutions, and how do we engage that time to improve health as well. Yeah,
and it's also about it's a very good question. Are we really using our time efficiently with the acute care problems that we actually have,
mm-hmm.
And particularly the time for different types of people, physicians and nurses and other people. Could we serve in team-based models or OHT models more efficiently around the acute care sector so that we could reserve time more for the second curve?
Mm-hmm.
Thank you. So I have another question here, and this actually came up in my session at the 2-day forum. How do we weave in qualitative data alongside quantitative for population segmentation? Is there a role for non-quantitative data in population health management is a broader question.
Absolutely. This is a lot about combining the quantitative information that we have, often which is from administrative sources or our electronic medical records that paint one picture, but bringing in patient experiences, people and caregiver experiences to really make sense of it is key. I think a great starting point, which I know some teams have done, which is is actually bring together groups of patients, caregivers, providers to actually reflect on data together and say, how do we make sense of this? Why is it that we're seeing this pattern, this distribution? And then let's say, how do we develop and co-design a pathway that's going to change that? It's interesting with the COVID work and everything that's happening. I think that almost the population is getting familiar with the idea of flattening the curve, which is in epidemic situations, the idea of reducing the rate of new cases. I think we're going to see the public increase their familiarity with talking about curves in terms of disease in other ways and how we need to shift it.
The comment about qualitative, from my perspective, the comment on qualitative data is actually particularly important because everybody is thinking that, oh my goodness, how are we going to do this if we don't have all the quantitative data that we would particularly need, and particularly around some of the socioeconomic risk factors, Andrew. And I know that many of the qualitative approaches around barriers, the qualitative are actually sometimes even better data sources than some of the quantitative data that we have.
Yeah.
That's really helpful. Thank you. One last question, and then I'll wrap it up. So Georgina is asking, without sufficient investment in the third curve, how likely are OHT activities in those first and second curves, I just lost the question, going to shift the curve? So can we do 1 and 2 without 3?
Yeah, I think that was also a really good question. I don't think we were talking about without 3 at all. So 3 is actually a fundamental part. We need to understand what the competencies in healthcare are to actually do the second curve. It is actually, we know that actually if we treat blood pressure consistently across a population, for instance, we can reduce stroke and cardiovascular mortality. That is clear, that it's all around delivering consistent care that we know works appropriately. So that is there. But we absolutely, I couldn't agree more as a public health doctor, and I know Andrew couldn't as well, is we actually have to fundamentally address some of the socioeconomic factors as well. And so that third curve is important, and we're going to come back to address that.
And okay, I want to sneak one more. Oh, sorry, Andrew. I want to sneak one more question in.
Sure. Yeah.
Is there a way to do that? Okay. So Laurel's asking, as an OHT in development, should we be discouraged from making a practice group, with quotes around that, the year 1 focus, and then segmenting that practice group, and instead go with one of the 4 groups that others have taken, and then segmenting within that disease? So strategy choice early on, what would you recommend? Is these 4 the ways that most commonly those first 30 have done it in terms of identifying people with mental health and addiction issues or palliative care? Is that the way to go, or where do you start?
I think it depends a bit, it depends a lot on your population and really if there's something that stands out. The other is there is going to be a synergy with working with other OHTs around priority populations and learning. And I suspect most OHTs are going to be doing both looking kind of at their own population and kind of letting that identify the groups as well as saying, here are some priorities.
Yeah. I mean, my perspective is this is a real shift in thinking, and we really have to think differently around segmenting populations in a new way according to what their differential needs are. That may be within a practice group. What are the populations served by that practice group, and how do we actually segment and serve those populations differently? So my perspective is that we really have to move into really focusing first on the population that we're trying to serve, understanding what their needs are, and then fitting the service model in as the second layer, not starting with the service model.
Got it. Okay, so we're at 1 o'clock, so we're at time. So just thank you, everybody, for sticking with us for the hour. This was very informative. I learn something new every time I hear the 2 of you speak. Just to point you to upcoming webinars related to those population or disease groups that was mentioned in that last question. We've got some coming up. If you have groups in your OHT interested in any of these particular areas. We're having webinars over the rest of March, and then we've got some coming up in April as well, which I've just itemized here. And we're developing some new resources. So stay tuned with RISE. And thanks again for everybody for joining us. And we'll see you next week. Thank you again to Andrew and Rob for your excellent presentation. Bye, everyone.
Thank you, guys.
Thank you.